my dear friend. And so I will present you my keynote lecture. I'm very honored to be invited for that. And I will tell you how to approach the iris tissue in different scenarios. The main question is, can I repair the iris tissue with iridoplasty using my iris, or the iris tissue is too much damaged? It's impossible to use the iris tissue. So in that case, I need an artificial iris. So this is the main question. So I just show you, okay, financial disclosure, okay? So I go, this is the question. Severe iris laceration, iridoplasty or artificial iris? Is there significant iris tissue present? If the answer is yes, we can use the original iris tissue of the patient during doing iris cerclage or Sipser sliding knot technique. So this is the basic concepts of iridoplasty. Mechanical technique is very old. Nowadays, most surgeons, like me and many others, prefer slip knot, sliding knot technique by Sipser. I show you some videos. Sipser sliding knot technique. Okay, first remember always to massage the iris tissue, to unroll the iris tissue before starting. Then you use one Prolene 10-0 suture, single arm. You just need one needle. You start from one paracentesis, and now you pull back the suture through the first paracentesis. In this way, you create a loop. Now you see, I have a loop. So I pass the loop 3 times on my forceps. I take one side of the suture, then I go to the other side of the suture, and I pull. Now, pulling little by little, you see the 2 sides of the iris tissue go together and close the pupil. I do the same again on the contrary. So I create a loop, I take the loop, but this time on the contrary direction, just one time. I pull again, and then I cut the suture with the micro forceps, like a vitreoretinal micro forceps, micro scissors, excuse me. So now I do the same on the other side of the pupil. Again, Prolene 10-0, the needle, and then I pull the loop out of the anterior chamber through the first paracentesis. I take the loop, I pass the loop 3 times on my forceps. 1, 2, 3, 1, 2, 3. And then I take one side of the suture, I do again. I take one side of the suture, I take the other side of the suture, I pull the 2 sides of the suture. You see the loop goes inside the anterior chamber and gently put together the 2 sides of the iris tissue. I do the same again. On the contrary, it's very important to block the suture, like 3-1-1. In this case, I just do 3-1. Now, another trick. The pupil is good, okay, but it's a little triangular, for example. So if you want a better shape, a magic trick is endodiathermy. Endodiathermy on the stroma near the pupil. You see here, and you see endodiathermy can move the iris tissue. So in this way, I do gently the small touches of endodiathermy on the stroma of the iris tissue, and in this way the pupil will become round. Little by little, you can do a lot of times until you reach the good round pupil. So better shape. And then this is the end of the case. I'm using usually anterior chamber maintainer, as you can see, and a bubble of air at the end. So this case, you see, pre-operation, this patient had a big mydriasis after iatrogenic trauma for cataract surgery. He had many years before. So the patient was like that, with mydriasis, atrophic iris, photophobia, and now the pupil is round, and you see also aesthetic result and functional result, because photophobia now is over. And 2 weeks post-operation, you can see with high magnification the two points of the suture of Sipser. Okay, another case. This was traumatic subluxated cataract surgery with zonal dialysis and mydriasis post-traumatic. So I put a capsule tension ring. I just need to do the cataract surgery. Pay attention, of course, there was zonal dialysis, but now we are focusing on the iris. So I just skip the part of the phaco. I can save the capsular bag, so I can implant IOL in the bag. And now iris tissue. I repeat. First thing, you have to massage to unroll the iris tissue from the angle to the center with bimanual maneuvers, because you need more tissue. So after massaging the iris tissue, again, I am performing Sipser sliding knot technique, prolint and zero, from one side to the other side. Then I create my loop. I pass the loop 3 times on the forceps, 1, 2, 3. I take one side of the suture, then I go to the other side of the suture, now, and I pull. And when I pull both sides of the suture, the iris tissue go together, you see, like that. You have to be very gentle, because if you pull too much, the iris tissue can bleed, of course. So I'm doing another Sipser sliding knot here. The other option would be iris cerclage. Iris cerclage is a fantastic technique. In my opinion, it's very difficult, because it's one long continuous suture, so you cannot do mistakes. Because if you do one mistake, you have to do again. So I prefer sometimes to put multiple Sipser sliding knots. Usually, to correct the mydriasis like that, you need 2 or maximum 3 Sipser sliding knots. For example, now I did two Sipser sliding knots, but I was not happy, so I wanted to do another one. So I put a third Sipser sliding knot, but you see, I pulled too much, so immediate bleeding. So pay attention, because iris tissue can bleed very easily. So this is the last Sipser sliding knot. And again, I'm creating my loop. And very gently, I am completing the case. So this is the last one. But as you can see, with these 3 Sipser sliding knots, the pupil is quite good. And in this case, again, I'm using endodiathermy to obtain a better, rounder pupil. So you see here, now with the endodiathermy, you just touch the iris stroma, now, like now, you see, and now you see again, tack. Not on the pupil, a little bit like 1 millimeter from the pupil contour. And this is the end of the case. So, for example, if you see the beginning of the case now, at the beginning, you could think that there is no iris. For example, the beginning of the case was like that. You could say, oh, there is iris coloboma, there is iris. No, the iris was there, but the iris was hidden under the angle. So that's why you need to massage, to unroll, because many times after trauma, the iris is just hidden. Not always, sometimes. Okay, I showed you this case. Okay, I want to show you this case now, because this is a borderline case. Because in this case, for example, it was not possible to do iridoplasty. And in this case, you have to choose for artificial iris. Why? Because this patient came to our clinic many years after the trauma. He had the trauma when he was a kid, he didn't do operation, and after 20 years, 30 years, he came to our clinic. But now, after 30 years, the iris tissue is fibrotic, is rigid, is inelastic. So I want to show you, I try to do Sipser sliding knot technique, but it doesn't work because iris tissue is like plastic. This is the operation. Oh, no, sorry. There was, I want to show again the video, sorry. Okay. I just go back to the point. This is the capsular axis. There was a huge zonulodialysis here, traumatic cataract, and I could do capsular axis, and I was not sure to manage this, but also because the iris tissue was very rigid. So this was just my attempt. Because you have to remember that artificial iris, at least in Italy, it's very expensive, very, very expensive, and usually in public hospital is not present. So when you have a patient in the public hospital, you try to do iridoplasty because it's free. But if you cannot do iridoplasty, you have to stop. You have to tell to the patient that artificial iris is an option, but it's very expensive. So sometimes patients, I mean, it's not easy. So this was my first attempt to save the iris, but I couldn't do it. So I was realizing that probably it was a case of artificial iris, but I just show you my attempt. I'm using triamcinolone to clean it, but now I prefer to remove the capsular bag because in my opinion it was too much zonulodialysis and I had to deal with the iris. So I prefer to remove and to clean everything to prepare for the implantation in the second time. Now I just try to obtain a pupil from this iris. Again, triamcinolone, anterior vitrectomy. Now everything is very clean, so I put anterior chamber maintainer, and look here, I'm trying to do as usual massage of the iris, unrolling of the iris, but now in this time it doesn't work because the iris tissue is too rigid. It's like plastic, you see, it's not foldable, so it doesn't work. Actually, I am pulling the iris and I'm creating iridodialysis. So it's time to stop. It's impossible. I just try my last attempt to do the suture. I'm trying to do Sipser sliding knot with Prolen 10-0 suture, just to try. You never know. But as you can see here, now it will be evident that it's not possible. So I show you this case because this is the moment to understand that we cannot do that. So artificial iris in this case is the only option. So for example, now I'm using the needle. This is Prolene 10-0 needle as usual, but I'm doing the usual steps of Sipser sliding knot. But now, as you can see, when I'm trying to pull the sides of the suture, the iris tissue doesn't move. Actually, it breaks. You see here, it's like plastic really. So I just stopped. I told to the patient, we cannot do that. So then in this case, this is a particular story because the patient told me it's impossible because the patient didn't have the money to pay the artificial iris prosthesis. So after some months in Italy, I was invited to National Congress Ocular Trauma in Rome to operate live surgery, and they asked me to operate in live surgery artificial iris prosthesis. So I called the patient and said, if you want, I can operate you during live surgery. In this way, the artificial iris will be free because the company will give it for free. So I operate him with artificial iris in live surgery. This is the video taken in Rome during the Congress. And so this is a happy ending of the story because this is the same patient after some months. You see the iris tissue is still there with this big mydriasis. So I'm preparing for the artificial iris implantation. It's a scleral fixation of 3 points. I am sitting at 12 o'clock, and the scleral fixation is 12 o'clock, 4 o'clock, 8 o'clock. So I'm preparing the 3 scleral flaps and the anterior chamber maintainer. This is the artificial iris prosthesis by Rapper. Rapper is artificial iris prosthesis with IOL included. So IOL is inside the artificial iris. So it's the best for the surgeon. When you order it, you have to choose the color and the IOL diopter. So now I inserted the artificial iris prosthesis in the anterior chamber, actually in the posterior chamber, behind the original iris tissue. And now the fixation is at 2 millimeters from the limbus, like a normal scleral fixation. So this is the last suture. I'm using Prolin 10-0, and I like this loop suture because the suture is a loop. So I don't need the 2 needles, I just need 1 needle with the loop, and it's easier. So now I'm closing the corneal opening. This is the normal closure of the corneal opening, and this is the end. Of course, it's important that artificial iris must be behind the original iris tissue, behind, not over, otherwise you block the angle, of course. So as you can see here, this is the end of the case, and 5 months later, you see the pupil is well centered, the cornea is clear, and you see the original iris remnants, very light, in front of the artificial iris. So we have 3 models of artificial iris. Marker, actually, it's very old model, no color, just black, so not very good, and PMMA, so you need a huge corneal opening, more than 12 millimeters, so it's not the best option. Human optics is very good for cosmesis, for aesthetic result, but there is not IOL, it's only artificial iris, and it's very expensive. When you use artificial iris human optics, you have to reduce diameter according to white diameter, because it's very big. So you cannot put inside the eye. You have to reduce diameter and then insert in the eye. We did a lot of publications on this surgery. Also, my father, Matteo Forlini, my father before me, published some cases like in 2010, 2012, so many years ago. And Rapper artificial iris, I just show you, I think is the best option because IOL is included. It's already the good diameter. You see there are already 3 iridectomies, so the aqueous humor can flow, and there are already 3 small holes for the scleral fixation. So it's very easy to implant. And I don't know, I have one case to show if you want. One last case? No? Time. Okay, it's okay. Anyway, this is one case I did with artificial iris. Human optics is very good for aesthetic result. This girl was very young, 26 years old, so you can imagine the aesthetic result is very important, and also the functional result. So she was very happy. You see, after 3 weeks, and this is the iris plane in the Scheimpflug camera. So 3 months later, the aesthetic result is very, very nice. So I just conclude because time is finished, and I just want to thank you again for the kind invitation. And this is San Marino, where I live in Italy. So thank you. Maybe see you next year.
Thank you so much, Matteo. It was a wonderful presentation.